I was going to say, do you want me behind you? Because
No.
Med school, I was always in the back.
Time. Make sure you tune in.
Scoot this way a little bit better. You're like on the edge of the screen. There you go.
All right.
Get you into the screen.
The champ is here! The champ is here! The champ is here!
Mike Kingbiz, ESPN Richmond, the champ of Business Talk Radio. On the mic, Mike King back. I have the best. Why? Because I rock with the best. Hey, I got my man, Dr. Capri. The painkiller is in the house. With this, Doc, welcome back to the program.
Appreciate you.
All righty, really quickly, tell folks who you are and what you do.
Well, I'm the painkiller. Half of America's in pain right now. So if it's not me, it's you.
You know what? I'm not even going to lie. I am not sitting here pain-free. And I've had, as we talked before you came on air, there were a couple business decisions this morning, whether something was going to be the bad part about a business decision of picking something up off the floor, if you have no choice but to get it. Mm-hmm. Now you have to figure out a way. Getting down may not be the issue. Mm-hmm. It's that getting up. Yes, sir. Yep.
And that'll also tell you that you're too weak for your weekend.
You know what? I use that one now. People live for the weekend. But you get to Friday and you're like, oh, well, I'm too broken down. Now you can't do anything. So you need 48 hours to recuperate. Now you got to go back on the treadmill again. There we go. All right. So, Dr. Capri, you always know some really cool people. Oh, shout out to the Children's Hospital Foundation. They just opened. We were rocking there last week. We stopped by. So, shout out to those good folks over there. So, now you came in. You got a different business model. Mm-hmm. You say, I can get rid of pain in
3 visits.
That's almost that almost sounds like I can name that tune in 3 notes. Yes, I can do. You get rid of your pain. Yours is a different business model. It's not you guys are going together forever and ever. So you bring a doctor in here who has a business model as crazy as yours. Yes, sir. Doc, welcome to the program.
Thanks for having me.
All right, tell folks who you are and what you do.
I'm Dr. Dan, and my practice, Revolution Medicine, Direct Primary Care, which is way too long, so we call it RevMed. What I do is give basically unrestricted primary care to my patients in exchange for a monthly fee. And what I mean by unrestricted is when they need me, they can get a hold of me, whether it's in the office, on the phone, through secure messaging, texting, email, however they want to contact me.
Old school doctoring.
Basically, yes. Is to say, hey, we've gotten way too far away from being able to actually have a relationship with our patients. And we're now seeing people for these 15, 7-minute increments. It's not enough time to have an actual conversation with somebody about anything, let alone anything important. So that model that most of us are using is not working for anybody. Doctors don't like it. Patients don't like it. It's not giving very effective care. So how do we get away from that and go back to the way things used to be, where you used to be able to have a relationship with your physician? And that's where direct primary care kind of comes in.
So shout out to my man, Dr. Joe, down at Dandelion. Why is it a cool doc? You guys don't just go by like Dr. Joe or Dr. Dan. Other doctors who don't have this business model, they seem to go with the whole credentials.
I mean, it's. I used to hear somebody complain when doctors are in restaurants. They'll go up and they'll say, "Hey, Mr. Moore," and be like, "No, that's Dr. Moore." So, well, you're not operating here. You're not diagnosing a disease. You're a dude in a restaurant. I guess it just comes from, we're around a lot of pretense and a lot of pageantry sometimes in medical school. And I think a lot of us that do primary care, we're not so much into that. So yeah, we got the MD or the DO, we earned it, yada, yada, yada. But I'm also just, I want you to be able to talk to me. Not
okay.
Say, ooh, the doctor.
So you said the patient doesn't win with the old model. The doctor doesn't win with the old model. Does the insurance company win with the old model?
I mean, I would say if anybody's winning with the old model, the insurance company is probably winning with the old model because, they're some of the most profitable, if not the most profitable industries in the country. I mean, the new oil rush is healthcare, and the insurance companies are not doing poorly. That's for sure.
So, doctor, when you both of you guys, when you go and you explain your business model to your colleague.
Oh, sure. So
there you go.
Very good question. So when I explain it to a colleague, it's saying we are basically trying to divorce ourselves from the insurance system entirely when it comes to primary care. Our practice is talking to people, figuring out what's wrong with them, and fixing the problem. And the best way to do that is to actually have a relationship with somebody. A lot of people don't realize, but when we see a patient, that's considered for billing purposes to be a procedure. Now, seeing a person is not a procedure, but that's how we bill for it. And when you bill for a procedure, if I get in the room, talk to the patient, get the information that's required for the purposes of billing that code, and get out of the room, I will make as much money seeing that patient as I will if I spend, 25 minutes in the room with them actually having a conversation. It's the exact same amount of money. So the financial incentive and the way practices are structured is get into that room, get the information you need, and get out. And if I can do that in 2 minutes versus 25 minutes, I'm making the practice a lot more money. And that's where the motive is.
That's where the problem happens.
And most of us, and when I say doctors don't like it, sometimes it surprises people, but most primary care doctors especially, but a lot of other doctors too, really do not like that model at all, because it puts the pressure on us through financial pressure, sure, but also through our fellow employees, other people that are depending on us. We've got to move as fast as we can to keep cranking out those codes, but those codes don't take into account things like, does the patient agree with what I'm saying? Are they comfortable with the plan? Are they actually going to take a medication that I'm prescribing? Do they have questions? Do they fully understand what we're talking about in a way that makes sense? None of that is important to the evaluation and management code. So what I do is to say, okay, let's take that out of the equation entirely and say, you're somebody who's coming to me because you have a health problem or you want to prevent a health problem. Let's sit down and talk about the best way to do this. The way to most effectively do that is to have enough time for a conversation, 30, 60 minutes, and also not have the barriers to care. You'll notice if you ever call a doctor's office, right, you're never going to get a doctor on the phone. It is impossible because they don't get compensated for time they spend on the phone. And the pandemic gave a little leeway in there where they started to compensate a little bit more for telemedicine. That's been rolled back pretty consistently. So for most practices, they don't get any money unless you're in the office. So they're going to have you come into the office. Whether or not you actually really need to be in the office, that's the way it's going to work. I give probably 60 to 70% of my care over the phone. Whether that's through email, through text, secure messaging, of course, we use. And I do telemedicine, and I do office visits, and I do procedures in my office, but it's way less efficient that way. I can see a lot more patients a lot more effectively and with a lot more convenience for them if I'm just doing it using technology we've had for over 100 years.
So one of the things that when I talked to Dr. Joe and another OB doctor, and she had said, I said, and you talk about that practice part of the business side of it. I said, so when do you learn that in medical school? Nah.
You don't.
I'm like, okay, so now so you learn all the doctoring things, and now all of a sudden you got to go out there for the shock of a lifetime and do the business side. And all that business stuff takes away from the patient care, which you wanted to do in the first place.
That's correct. Yeah, we basically I spend a lot of time in medical school here in Richmond learning how to take care of patients, how to do it effectively, and then a lot of residency, not all of it, thank goodness, but a lot of residency was learning how to not do that, to see patients as quickly as possible, to get through my 22 patients in 7 hours or whatever the industry standard is. That was really disheartening because for most of us, that's not what we went into medicine to do. We went into medicine to make a difference in people's lives and try and help people as best we can using our knowledge. You can't do that in 7 minutes or 4 minutes of FaceTime.
No, you can't. On the mic with Mike, you got the doctors in the house. That's like the TV show, The Doctors. Yeah, that is one of the parts. So I was in the Army and on a team. You got commo people, demolitions, intelligence. I was a medic. No matter where you go, the medic is the person who is the most popular. Why? Because you can make people's kids, you can make people well. Talk about that. So when people come into your practice, people come in to see you, and you see what you did worked. That's the part. So for all of the other stuff you got to do, figuring out whether this business is going to work, all those things, you saw a person came in pain, or they needed help, and you were able to help them. So talk about that part for you as a medical practitioner.
Well, that's why you got into it, right? Is to see somebody walk out of your office completely different than they walked in. I had a guy come in the other Sunday because it was an emergency, right? So had him come in on Sunday morning, and he had actually bought a cane because he couldn't get out of bed, he couldn't stand up from seated, and he was like, the biggest thing for him was, I want to be able to walk my dog again. I haven't been able to do that. And he was getting up from laying down, like laying to seated, and then from seated to standing and walking immediately, and didn't use the cane again. And that was just the first visit. Now, we had work to do to get him to walk his dog again, but being able to get up and walk, an hour after I meet you is a beautiful thing.
One of the things you had also talked about is the communication between doctors. Like you said, a lot of you're like, oh man, go ahead, explain that part.
Well, part of the system is you're so busy doing what you have to do, and you have so much external pressure to try to get your job done as quickly as possible. And there's no compensation for the practice that you work for if you contact, another doctor. It's people just don't play well in the sandbox a lot of times because of that, because they have so much else to do. It just gets pushed down the priority list. But a primary care doctor needs to be the quarterback. He's got to be able to coordinate all the care through the different specialties. And how's he going to do that if I don't send him notes?
Okay. You always want. Okay, let's go back. You always want to be a doctor?
Yeah, I'd say so. Mm-hmm.
When did you settle on primary care?
Well, I didn't settle on primary care. I went into medicine because I wanted to do primary care. I worked for a doctor in Northern Virginia who had a similar business model to this, moved away from insurance, and this was before direct primary care was even a thing. What Dr. Joe does, what I do, what other doctors in the area do. And when I saw the difference he was able to make in people's lives, I said, okay, yeah, when I want to go into medicine and I want to do primary care. It's an old joke that the doctors who do worst in their class end up doing family medicine. I'm not going to toot my horn because I did well. I did very well at VCU, and that was even among medical students who are brilliant people. I didn't settle on primary care. I wanted to do primary care. It's where you get the best relationship with your patients because you know them better than anyone else.
One of the things, on the mic, we got the doctors in the house. One of the things that we always talk about is patient care. The doctor walks in, family sitting there, everyone's looking kind of, I'm not exactly sure. They all have that look on their face. You've seen that look a million times. Doctor says, all right, folks, any questions to the patient? To the family, any questions? No. Doctor says, all righty, folks, you have a great day, and contact me if you need anything. Doctor walks out, 100 questions to the nurse. So when he said this, or when she said that, what did they mean? That is not comfortable with the doctor. But now, what you do now is, and a lot of times, it's easier and better with the primary care doctor. It gets a little bit like that with the specialist, because they're really on skates. They're in there, they take care of what they're doing, and they're out. When we sat with Dr. Joe, you're talking about that intake. You're talking an hour of medical questions to the point where people are like, okay, really? I didn't know I had this much medical history. Because why? We're not used to that.
Right.
We're not used to. So when the doctor comes in, both of you guys have that bedside manner. Talk about why that's important. Because as soon as you leave, you're asking the nurse, "Well, so how many times a day did he say? And why am I taking this?"
So that really gets to the heart of it. I mean, part of our job has always been, I mean, going back to probably Galen, Hippocrates, I mean, long time ago, is to talk to people to help them understand what's going on. And we have moved away from that to where the doctor, I mean, you can tell usually by their body language that they want to get out of that room as fast as possible.
Yes, yes, sir.
And you know that when they come in, and they may ask you if you have questions, but they're sending a pretty clear signal most of the time, and they may not even be trying to. In fact, most of them aren't, but they're thinking in their head, I'm already an hour behind. I got to get out of this room. I got to get back because my staff's going to be here till 6 and they're going to hate me. So it's a very different experience to be able to sit in a room and talk to somebody for that 60 or 90-minute visit. And I have had people say, I got to go home.
Doc, that's cold. They're telling the doctor, yo, man, because yo, doc.
That was funny because it's the first time I've had that happen as a patient said, I think I got to go. I don't have anything else I can tell you.
But you warned them going, but I didn't believe you. Like we're
That's
sitting
correct.
there with Dr. Joe, and I'm like, man, we've been here a long time.
He's taken a history the way that we were trained.
And we're not used to it anymore.
No, we don't do it anymore. We just don't do it anymore. You learn what you have to ask, and there's always that big sheet they have you fill out before you go into the room where you check off a billion things.
We didn't read question past 4.
Exactly. And most of the time, we may glance at it, we may not. So it's frustrating, but that's where we're getting the history. You get the history by talking to the patient.
Alrighty, gentlemen, you are both medical professionals. I don't know if we need you guys anymore. Really. Because that Google thing, we can just, what I need you for? Whatever it is, I can find it in Google. The scary part is I have everything when you come in there. Talk about people doing self-diagnosis with WebMD and all of these things right there.
So here's my piece on this.
Okay,
right?
here
so
we go.
I'm much more on the specialist side, right? But muscle and joint pain is so common that I get 1,000 different things and so many wrong diagnoses. So if we're talking about 7 minutes with a doctor is not enough time, your computer's not spending any time with you. And cough may be a symptom, but how many different types of coughs are there, Dan?
It depends what you say. There's really one type of cough, but what causes the cough? You're absolutely right.
Well,
that could be
like
anything.
Cough and croup,
Correct.
all those different. So, like you say, cough, and is it a wet cough? Is it a dry cough? So,
we have those things. The other one is the medications on TV.
Mm-hmm.
Now, I do have a cough, and if you take this pill, I'll stop coughing. The problem is the 22 other things. When they told me that I could stop coughing, they were talking in a nice tone. They were talking nice to me. They were, violins are playing. It was nice. And then when they got to the side effects, they start talking real fast. Always. And the music changed. And it kind of got blurry because I couldn't read it anymore. And next thing you know, they dropped that last one, which is, it could possibly lead to death. So wait a second. I might die to get rid of this cough. I think I'm just going to keep this cough right now and go see the doc because I don't trust it. So, gentlemen, please explain to the listeners why they don't need to be self-diagnosing with WebMD and Google and everything else.
Well, I think it's a double-edged sword because it does allow patients sometimes to get a lot more information, especially when I've seen patients who've been through the traditional system and the doctor just doesn't have time. They'll go out and research on their own. That's not necessarily a bad thing. But
Correct.
The self-diagnosis does get to be very problematic because people suffer from what we call in medical school second-year syndrome, which is your second year of medical school, you learn all the pathology. In other words, every single thing that can go wrong and all the symptoms and things to look for with that. And we all think, and these are people in their 20s and early 30s, prime of our lives, who are convinced that we have some exotic form of histiocytosis, which is incredibly rare, but it's a degenerative disease that's going to kill us because we have an itch somewhere. And that itch, comes back from time to time. And my God, what could it be? And you've just learned about it in, your pathology. So we get terrified of it. Now you've got everybody can
Yes.
do that. And I think that's why it's important to have a doctor you can contact fairly easily, because you say, hey, I got this pain here. Do I have appendicitis? I say, okay, well, let's, first of all, you're talking to me and you're not doubled over in pain. So that's probably a good sign. If it is appendicitis, we've got some time to figure it out before we send you to the emergency room. And with enough of a conversation, getting symptoms, usually in the office, poking at your belly, but it can sometimes be over the phone. I can tell you, the chances that we're dealing with appendicitis are probably about as good as, you winning the lottery a couple times in a row. So I think we're safe to wait on this and see. It's helpful, but I understand why people use it. And the main reason is because they can't get a hold of us. They can't talk to us. They can't ask us questions. And, and they can't, which I get a lot and I actually really enjoy, is when patients will come in and debate stuff with me. Is they'll say, well, you had this wrong. And I'll say, yeah, we totally had that wrong. You're absolutely right. We screwed something up.
Now, how many times have you heard a doctor
right? I really, and I've been in the medical field a long time. A lot of times it wasn't, a person didn't come back to the doc. They may have thought it like, man, doc blew this one. But doc blew this one, but this is me. But I didn't think that until recently, and I say recently, when people start seeing the amount of ads on TV for medical things, that all of a sudden you just needed a doctor. Just Dr. Dan, man, just prescribe this thing right here, and I'm out the door. Why? Because I saw it on TV. They said they had those things. But I didn't think in the past people were that confrontational or to the doctor.
We've lost a lot of the prestige that used to go along with it. And some people do come at you like, you're a vending machine and say, hey, I need this, go ahead and write me for it. It's to say, like you say, one of the side effects of this is death, and you don't need it. So, the drug company would be very happy if I wrote for it, and it would allow me to upcode your visit if I'm working in the traditional system. But you don't need the medication. Let's, try something else, or let's talk about why you're thinking you need the medicine.
Alrighty, Doc, let's go down through some, not just the plans, ages. How does your practice work? So it's for families?
It can be for individuals or families. I see my youngest patient they're now significantly older, but was 3 weeks old, and my oldest patient is 88. And I can see anybody of any age. And people on my website, www.revmedrva.com, that's got my plans listed, but I can break them down for you if you want to.
Really quickly.
So $75 one time to register. And then if you're 18 to 39, it is $69 a month. If you are 40 to 64, it is $79 a month. If you are 65 and older, it's $94 a month. Additional members of the household I discount for. Kids are $49 a month, but if they have a parent's membership as well, it's $29 a month. And that covers all of their office visits, all of their telephone communication, text message. If you don't need me at all in the month, it's the same price. If you need me 10 times that month, it's the same price. I don't have to think about it when you contact me. I don't have to worry about billing. I don't have to do any of that. It's totally compatible with essentially any insurance. Your insurance doesn't stop functioning. It's just saying, hey, when I have a primary care need, that's kind of like my car needing an oil change or a tune-up. They need those from time to time. If you're paying your car insurance company a premium that covers all of those, and you went to your mechanic and said, okay, here's my insurance card, they'll take care of the tune-up, you're not going to end up paying less money by paying someone else to pay that mechanic shop. That's something you're going to need. And it's a lot less expensive in the end than when people go directly to the doctor.
Okay. And once again, how can people find you out there?
It's revmedrva.com. And they can also just Google my name, Dr. Dan Moore, Richmond, Virginia.
Really quickly, what did COVID do as far as you do home visits as well too?
I do home visits. Yeah, that's the only thing I charge separately for. Members I see for $139 a visit, and there's no limit on time. Non-members I can do house calls for. I do $350 for the first hour, and then $150 for every hour portion thereof.
Which is different. How many other people do home visits?
You can get a lot of places that will do home visits. The problem is that not to disparage them, but they will not usually send a physician. They'll send
something other.
They'll send an NP, nurse practitioner, or they'll send a physician's assistant. Some of them are very good, but they don't necessarily have the training that we do. And they also are on that procedure-based model. So their incentive is to get in and get out as fast as possible. I don't have that.
There you go, Dr. Joe. Some words of wisdom for us and take us out of here to get out of pain, besides contacting Wellspring Chiropractic.
Well, don't wait.
Don't
That's
wait.
the thing. Like, those things build up. You know, anything that you do consistently, you get better at. That includes feeling pain. So if you allow yourself to continue to feel pain over and over again, it doesn't take as much to feel the same amount of pain.
So what you had said before is people find their way around working with pain.
Yeah.
You walk a little different. You figure whether I really don't need to pick that thing up on the floor.
Right. Right.
I really don't, because you have a decision whether you're able to get back up.
Yeah. People are generally pretty tough. So, you know, they'll figure out a way to do what they need to do. But just like any defense mechanism, long term, it's going to cause other issues.
Doc, when did you know you had a model that worked?
Fortunately, other physicians have done this before me. So not only did it make a lot of sense, and seeing my mentor do it probably was the biggest thing. He never made as much money as he would have if he'd stayed in doing things the way that everybody does them now. But he was a heck of a lot happier doing what he did, and it let him do his job. And that's what allowed me to know how.
So do you do any dealings with insurance companies?
When I absolutely have to, in order to I don't ever get paid by an insurance company. But what I do is when a patient's insurance says, hey, you know, you ordered this CT scan that we're going to have to pay for, or at least put on the insurance deductible, you need to tell us why they need it. That's a whole other discussion about why that even exists in the first place. But I do those when I absolutely have to for patients, when they need forms filled out from their insurance company for purposes of justifying a home health need or something like that. So I interact with them when I absolutely have to, or when I write for medication and they say, hey, we need a prior authorization for this. I get on the phone, and I'm usually very annoyed by the time an hour goes by and I finally get to actually speak to somebody. And it usually is not a problem getting approval for it.
Where are you based out of?
I am over at Gayton Crossing, so I'm right off of the Gaskins Road exit in Weston right there.
All right, on the mic, Dr. Joe, how can people find information out about Wellspring?
Painfreerva.com.
You guys got some cool names. The names stick out. So on the mic of Mike, we are the best business radio program. You can follow me on social platforms on the mic of Mike, as well as Mike King Biz. Yeah. So I have these guys in here. They're so good. Their services are like this.
On the mic with Mike RVA is the best business radio.
It's so good. You have to whisper it. So, you know, you can't be in places talking loud, you know. So Dr. Dan is here with this Dr. Joe Capri as well. On the mic, Mike, we are the best business radio program. We have to go. So make sure you continue to follow our sponsors and advertisers like Dr. Capri right here. And because they're out there doing some really cool things, supporting the community as well. Oh, yeah, we got to talk. The next time you're back, we're with, what's it, Tool?
The Tool Bank RVA.
Richmond
Tool Bank.
Richmond Tool Bank. So you're out there helping the nonprofit. It helps the nonprofit.
Yeah.
That's why I rock like that guy right there.
Who helps the helpers? That's
Because you know what I always say? who takes care of the caregiver? Because the caregiver won't stop. They are not built to stop.
Amen.
Yeah,
No, caregiver fatigue. That's another thing. You're taking care of somebody at home because they got a health problem. It's a huge under-recognized problem that if you're taking care of somebody at home, you need to get some help to help take care of yourself, and that can be hard. But please find a way to get some relief. Find a way to help take care of yourself. Taking care of one person at home is 3 full-time jobs.
because I had been in the Army. I was a medic, and I was pretty good. I was good. But I never got the part to put your mask on first on an airplane. I didn't. Because the natural inclination is to help the next person. They're like, yo, if you fall out,
Can't help them. That's exactly right.
It's a wrap. So, Dr. Dan, Dr. Joe, we got to go on the mic with Mike. We'll talk to you soon.